All right. Well, I just wanted to thank everyone for being here with us today and welcome you to this session of the Northeast Ohio Opioid Education Series. This series is supported by a grant from the CDC's OD2A local grant, which is the Overdose Data to Action grant here in Cuyahoga County. My name is Rachel Summer, and I'm honored to open this discussion on a truly transformative approach to healthcare. The primary practice physician program for chronic pain, or 4PCP, we'll be discussing today. And in this session, we aim to address the complex nature of chronic pain treatment among clinical providers, and we're just so glad you've joined us. So to lead us through this biobehavioral framework, we're joined by two distinguished experts, Dr. Jeffrey Janata, Chief of the Division of Psychology at University Hospitals, Cleveland Medical Center, and Dr. Albert Musa. Together, they will introduce us to the core of 4PCP. This program is specifically designed for primary care practitioners to better support patients living with chronic pain. So today, we aren't just looking at symptoms, we're looking at a change in how we speak to, treat, and empower our patients. And with that being said, I'll turn things over to our presenters. Feel free to enter questions in the chat, and we will make sure we respond to those either as we're going or at the end of our conversation. And yeah, I'll let you guys introduce yourselves and we'll move on from here.
Very good. Thank you so much, Rachel. I'm not actually seeing that whole slide.
Sorry, what can you see?
Al's name should be there as well. It's on the,
okay.
There are both, anyway, both names are on there. I don't want to shortchange my colleague, Dr. Musa.
We may have dropped some things when we copied it over from the slide deck and merged them together. I noticed sometimes that happens, so I apologize.
No, that's all right. We'll navigate it, but I just want to make sure that he doesn't feel slighted.
Not in the least.
All right, so I'm Jeff Janata. I'm here in Cleveland at Case Western Reserve University. I'm a professor in the Department of Psychiatry and have had a long-standing interest in chronic pain. For 30 years or so, we treated chronic pain in an interdisciplinary fashion, and I'll tell you a little bit more as we go along about the development of our clinical service, and then ultimately our educational offering as well. And Dr. Musa, would you like to introduce yourself?
Yeah, Al Musa. I practice general internal medicine for 40 years in Madison, Wisconsin. Just a disclaimer from that previous slide. I wasn't chief of the university hospital. I was actually a board chair for our Dean Medical Group here in Madison, which is part of SSM Health. I recently retired, but certainly have 40 years of the journey in chronic pain to participate in a discussion. It certainly was a journey from we're under-treating pain to overuse of opioid, and how do we reset both, patient and clinician expectations, continue and go forward for better outcomes and more safety.
And I will tell you that Al was very instrumental. I come at this from the behavioral perspective. My longtime colleague, Dr. Chilimsky, comes at it from the neurologic perspective. But it was critically important for us as we developed a curriculum, excuse me, to hear from and have the advice of and the significant contribution of primary care practitioners as well. And so Dr. Musa, along with Dr. Phil Bain, who is from Montana now, were very generous in collaborating with us and helping us understand the perspective of the community practitioner and how the challenges really of managing patients with chronic pain in a community office, in a primary care office, and helped us to orient the curriculum that we ultimately designed to their needs. So we're very appreciative of his longtime collaboration and friendship. So, 4PCP. 4PCP is an acronym. It stands for the Primary Practice Practitioner Program for Chronic Pain. And cleverly, as we always try to do, it also condenses to 4 PCPs, or 4 patients with chronic pain. So the 4 PCP program was really born about 15 years or so ago. I think you can move to the next slide now, Rachel. And I'll give you just a little bit of history. We operated at university hospitals. We operated a chronic pain program, Dr. Chilimsky and I did, that was interdisciplinary, involving psychiatry, neurology, anesthesiology, and rehabilitative services, OT and PT both, along with addiction medicine. And this was essentially an intensive outpatient program to manage folks who had chronic pain problems that had been treatment resistant. And we brought people into this outpatient setting. They spent all day, every day for 4 weeks working with us, and we had a remarkable success rate. It was a very effective program. We returned 71% of the patients we treated back to active life, whatever that meant. They returned to work, they returned to school, they returned to homemaking. They were able to resume their function, which was really an astonishingly high success rate. Unfortunately, it was a very stick with that first slide, please. It was a very expensive and labor-intensive way to treat chronic pain. So there were a lot of us involved, and at any given time, we would have anywhere between 8 and 12 patients in the program. But because of its labor-intensive nature, our program lost money. We lost about $100,000 a year. That doesn't sound like much, but for an institution that's trying to maintain a budget, $100,000 in the red suggested that ultimately they were unwilling to tolerate that and closed the program. So what we thought was, we actually heard from a lot of the primary care physicians who were referring into us that they really appreciated the program. And we thought, well, now why couldn't we train those same physicians, in essence, to do exactly what we did in our intensive outpatient program and in their own community offices? So we recruited 34 physicians and did a trial, a pilot study funded by the Macy Foundation to see if we couldn't train them to do the same sorts of things in their office that we were doing in our intensive outpatient program. And we published the findings in 2013 in a group of physicians who found it very distressing, really, to treat chronic pain patients. They found it challenging, and for a lot of different reasons. But it was a population of patients that were not preferred, I guess you might say. And one of our colleagues, Ted Perrin, an addictionologist here at Case, used the description of the heart sink patient to describe them. As you see them on your schedule the next day, you kind of say, oh gosh, Mrs. Jones, or Mr. Smith, I just don't know what to do. I don't feel like I'm being very helpful. I feel like it's complex. I feel like I'm not really meeting their needs. And in particular, I feel a real pressure to prescribe opiates, which I don't really want to do.
So, Jeff, just a few comments on how important this pilot was. Despite the short-term budgetary constraints of managing a multidisciplinary chronic pain clinic, the alternatives are that heart sink that primary care physicians experience in trying to address this, along with a myriad of other chronic illnesses within the short time of an office space, and that burnout factor in primary care, let alone downstream costs. I did a small study in our setting of taking care of identified high cost high intensity of care patients, and a third of them were chronic pain sufferers. So it's a real, the downstream costs are substantial, just hard to harvest and prove cost avoidance. And so I think there is so much merit to what this study is saying, despite the real world obstacles. And I guess the other comment I'd make is we've shifted so much to pain clinics being so procedural, and that works for some pain syndromes, but certainly many of them are totally non-responsive to those interventions. Those interventions are costly, and the pain syndrome obviously continues. So an alternative, we begs for an alternative.
Yeah, yeah. So we learned several things when we did this study. The first is that medical education does not spend a lot of time, frankly, on chronic pain. They spend a lot of time on acute pain. Medical students, residents learn about managing acute pain, but they don't spend much time on chronic pain. The average curriculum in medical schools at the time that we worked on this study, the average number of hours was about 4 hours on actually the thing that brings the majority of patients to see their physicians. And so a lot of the problem was that the physicians felt under-equipped, under-trained at this really very important presentation by patients. So we recruited these physicians in. As I say, there were 34 of them. And it was a 2-year study. We did 1 year with half the group, the second year with this other half of the group to kind of create a comparison group. And what we found at the conclusion of the study was that they felt that they had significantly improved their ability to diagnose and manage chronic pain. And most important, I think, honestly, was they had a significant increase in their own satisfaction with their treatment. So the physicians felt much more satisfied that they were doing a good job, that they lost that sense of heart sink with these patients. They felt as though they had a strategy to work well with them. The visit time, surprisingly, was reduced. We found, to our surprise, this wasn't something that we were looking for to begin with, but we found that once they really truly understood a strategy for managing chronic pain, that their visit times actually dropped from an average of 20 minutes to 11 minutes. A very significant finding, and particularly significant for the time pressure that most primary care physicians feel in the office. They're squeezed for time. And so it was an unexpected benefit of this training. And the patients, at the patient level, their pain levels went down, their pain ratings went down before, following their work with these physicians. Their affective pain, by which we mean the distress that they experienced as a consequence of pain and loss of function, and depression and fatigue all improved. So it was beneficial both for patients as well as the practitioners involved. So on the back of that study, then we thought, well, terrific. We're going to go get a lot of funding and we'll do this on a large scale basis. And we really we weren't able to attract funding to do a complete study of it until the opiate crisis came. And all of a sudden, people started knocking on our door and dusted off this article and said, gee, this might benefit us in an era where now we're really thinking about reducing our reliance on opiates. We're thinking about finding other strategies for managing chronic pain, and might this be helpful? We had contact from a number of different states who were interested in it. And so then we were able then to spend time to improve our curriculum. And that was this phase of time when Dr. Chilimsky and I met with Dr. Musa and others to codify this curriculum into something that we could then distribute to really to the nation. Okay, now you can switch, Rachel. So what we'd like to do is overview some elements of our program. We really can't overview them all, but we want to emphasize several different and kind of highlight several different aspects of the curriculum, and in essence the ways that this changes the way we think about pain. So first, we'd like to introduce something about the new pain neuroscience and the way thinking about pain from the neuroscience perspective changes how we think about pain, how we conceptualize it, and how we talk about it with our patients. And then that communication piece becomes critical in how it is that we help our patients understand the way that we're conceptualizing chronic pain, the shift from kind of a sensory model to a neuroscience model, and the importance of language in recruiting patients to our way of understanding pain. Third, we won't talk about as much, but it is critically important that we find that pain treatment is really best done as a team. And anybody who's been in an office trying to treat chronic pain in isolation will tell you that it's a comprehensive problem. And like most comprehensive problems, it requires a complex solution. And so the idea of having a team to work with, that's, a virtual team, not just all in a room together, but being able to have the skill and the framework for communicating effectively with physicians and psychologists and addictionologists and rehab specialists makes a whale of a difference in how it is that you not only effectively treat pain, but feel a sense of support for what you're trying to accomplish. And fourth, we use the stages of change model to help to tailor the interaction between practitioner and patient. So what we encourage practitioners to do is not spend too much time trying to convince a patient who's not ready to be convinced to change their way of thinking about this. And we'll talk about that a little bit more as this goes on. Okay, Rachel, thank you. So the first foundation of this approach, I think, is to understand the critical distinction between nociception and suffering. And this graphic kind of points out the various strings or strands that we sort of have to be sure to understand that differentiates nociception, which is really a pain signal that comes from the periphery into the brain, and we experience it as hurt, versus the suffering experience of patients with chronic pain that includes the things that you see here: loss of function and a sense of helplessness and frustration and anger and sense of loss and sense of anxiety. All of those things accompany chronic pain and actually serve to be, to a large extent, the drivers of the pain experience beyond the input from the sensory system. So we distinguish between nociception and suffering, honestly, in the same way that the legal system differentiates pain and suffering. You get an award, you're in an automobile accident, and you're injured, and the legal system long ago understood that there was a difference between pain and suffering, and they make an award based on that. They'll certain amount for pain, but a certain amount for suffering, all the consequences that surround the pain itself. So this is a distinction that we make for our patients, and we'll talk a little bit more about that in the next slide.
Jeff, just a comment, that is such a key point, and really it manifests in why we describe now chronic pain as a syndrome rather than a disease. And I use that analogy often to try to help patients understand a disease having very clear cause, effect, mechanism, and usually a very prescribed treatment then potentially. A syndrome is a constellation of symptoms, so it's more than about the input, and therefore the treatment becomes much more complex and multifaceted. I think that helped patients leave the old models of acute pain. And I know we'll talk more about that, but this concept is so key in making that transition for ourselves as clinicians, let alone the very challenging part of informing patients of why a different approach offers them a potential benefit.
Yeah, yeah. And it's an important thing, and a lot of our communication effort is helping physicians and other practitioners, and I don't mean to exclude other practitioners. I keep sort of short-circuiting to physicians, but this really is a practitioner program for physicians, nurse practitioners, physician assistants, psychologists, counselors, social workers, and occupational and physical therapists. So each of these practitioners learns this language and helps to reinforce each in turn this important change of paradigm really for patients. So this slide just details more of that distinction. Nociception is sensory input to the brain, and there's no emotional valence associated with it. There's no emotional accompaniment to it. It is simply a signal that doesn't have any meaning at all until we attach meaning to it. The suffering side is the brain's interpretation of that sensory input. It is the notion that there is a threat to bodily integrity, and that threat activates sympathetic nervous system arousal, the fight or flight response, and that nociceptive input now takes on meaning. It takes on concern about bodily integrity. It triggers recollections and memories of other painful incidents. And anybody who's had a small child, a little kid knows that when I go to my granddaughter and I kind of go to tickle her, I'm 5 or 6 inches away when she starts giggling already. I've had no nociceptive input whatsoever, but that little tickle kind of action triggers that response already. Pain works exactly the same way. Pain is an anticipatory phenomenon. It anticipates a kind of response that doesn't have to have any direct input whatsoever. So the distinction is important because patients often don't have any control over the sensory input, the low back pain, the foot pain, the CRPS pain, the headache pain. They may not have direct control over that sensory input, but what we talk about with them is they do have control over the suffering response itself, which is often tied to unreasonable assumptions and beliefs about pain, often tied to depressive or anxious responses. And so what we do is we help them understand that they can have control over the neurocognitive elements of chronic pain. And as a result, they learn to take control of the pain process as a part of our work with them. Okay, next slide, please. Okay, this is just a little placeholder slide, so you can continue on. Al, would you like to take this one, the difference between acute and chronic pain?
Yeah, and yes, Jeff, there's a substantial difference. And the acute pain framework experience, patients very strongly relate to because we've all experienced it so often. And there's a clear activation of the motor system, touching a burning candle as a classic stimulus that we've all experienced, the hot surface, and obviously you feel that tissue damage and that fact that in active pain there is more often than not tissue damage is an important differentiation from chronic pain is another very difficult thing to realign patients to in making that distinction. But obviously the healthy response is to remove your body part from that stimulus. And in acute pain, though there are known cases of patients that don't have nociceptive functions, and early death is typically around the age of 25, something they experience, and obviously because it's a protective mechanism. The in acute pain, in a psychologic analogy, would be sadness is a healthy response to loss to help us cope. Now, to contrast that in chronic pain, the brain changes are through suffering, and the motor cortex actually becomes inhibited. You're inactivating the motor systems. Reduce activity, there's fear of pain, increased stress, sleep disturbance, anxiety, and depression. So often a lot of passivity and deconditioning becomes an outcome of that. It often people then that are experiencing it ongoing and without a clear pathway to resolution or even relief begin to catastrophize, and it becomes a self-perpetuating cycle. The psychological analogy that we would liken it to is depression, which is also a brain disease, much like chronic pain. So why does it persist? We oftentimes chronic pain does become a part of an acute stimulus, such as low back surgery, and then the ultimate outcome becoming chronic pain. And the key is fostering resilience and not allowing that acute pain to spiral into chronic pain. And when it's clear that there seemed to be a link, at least temporally and historically, between an intervention such as that and then a chronic pain syndrome.
Yeah, thank you. I think the distinction is a profound one, and it has not been reasonably reliably made in the medical literature until relatively recently. But we all know when we see chronic pain patients, often they present with a kind of passivity and a sense that they're really looking to us to solve the problem, and they become increasingly passive. That passivity is a part of the chronic pain syndrome, and it is the motor cortex, contrary to what kind of seems intuitive. The motor cortex is where chronic pain is processed, not the sensory cortex, and so rehabilitative strategies which activate motor function, which get people moving again, which get people off the couch and re-engaged despite their inclination to be less active, is a large part of what we really try to do here to address the motor elements of chronic pain. Okay.
Jeff, I just comment in the practice environment, even as we re-educate ourselves in neuroscience to that differentiation between chronic pain and acute pain, the biggest challenge is still re-educating patients on that alternative because their experience is so ingrained in acute pain. It is a very challenging concept. And I think that educating that concept becomes key to lessen the reflex to depend on pharmacology and consider a broader biopsychosocial approach.
Yeah, it is, we're so conditioned to think of chronic pain as just acute pain that's been around for a long time, but it's a fundamentally different process. And I do think that, there's a whole pharmacy industry that is based on the idea that the way to treat pain of any kind is to block sensory input. Block it with the use of medications, with analgesics, with devices, with stimulators and intrathecal pumps, and but it is all focused on that sensory input. And honestly, we know better. If we study neuroscience, we know better that that's not really where chronic pain is maintained any longer. We still experience pain from the periphery. That's where the pain is localized to, but the chronic pain syndrome is maintained by the brain. So we're addressing the wrong stuff when we use opiates. We're addressing the wrong driver of pain, and we'll continue to kind of describe that as we go along. So next slide, please, Rachel. All right, so the difference between the biopharmacologic is that this nociceptive input is considered the primary mechanism, and the emphasis becomes on the symptom of pain itself, whereas a more biobehavioral kind of approach to chronic pain emphasizes function over pain severity. So we train our residents in our pain clinic. Typically they would say, well, how bad is your pain today? 0 to 10, how bad is it? We've now oriented them to asking first and foremost about function. How are you doing? How are you functioning? Are you able to do the things you need to do? Can you go to work? Can you mow the lawn? Can you pick up your grandchild? We're focused much more on treating function, which gets at the point of, again, motor cortex and function. So this biobehavioral approach that we're using now is one in which the physician or other practitioner explains these contributions, the role of the brain in chronic pain, focuses on the whole person's experience rather than specifically on symptom severity, and it doesn't eliminate the biologic. It doesn't mean that we don't use medications, but it means that we use those medications to facilitate behavioral activation. So we try to get to the point where we can address pain with analgesics, address depression, address anxiety, all potentially with the aid of medications, but ultimately for the point of activating them behaviorally, getting them to be more active and getting them to be more functional. So often what we'll say is, we'll have a quid pro quo. Yes, we'll be glad to address some of the sensory input, but you have to do your part in becoming more physically active. And that balance then creates a much better response to chronic pain than just emphasizing sensory input alone.
So Jeff, just a point on the pharmacology, the success that opioids had in acute pain management and just assuming and translating that to chronic pain has become problematic for obvious reasons, that the issue of tolerance, the issue of hyperalgesia with long-term use, and that issue of then increasing passivity, deconditioning, and long-term negative metabolic effects is what makes it not a preferred treatment. And again, not that it doesn't have targeted roles, but I think you made that point very clearly. The issue going forward is targeted for the goal of improving function.
Can you just describe hyperalgesia? I'm not sure everybody knows that term.
Longer term use of opioids seems to increase pain sensitivities and perception, and therefore that demand for an escalating dose, which I so often experienced in practice through many years. And so it was more than the issue of tolerance. Yeah. There's actually a physiologic phenomenon going on of pain sensitivity and how it's perceived at the receptor level.
Yeah, so there a lot of literature has now been able to demonstrate that long-term use of opiates increases pain. So in the immediate effect, it feels like it's decreasing it, but over the long haul, pain that there's a hyper response to the continued use of opiates that drives pain even higher. And as you say, that's one of the reasons why it's not just tolerance to the medication, it's truly hyperalgesia. So, all right, next slide, please. Did you make a comment, Rachel? I didn't. You kind of went by real fast. I didn't.
Oh, I was just saying that it's very shocking. I mean, I had no idea that that effect of the opioids on pain long term.
Yeah, hyperalgesia is not a common. I think it's not commonly known, um, but it is a replicable response to long-term opiate use. It increases. They increase pain overall. So the conversation with our patients then we call the biobehavioral conversation. That is the linkage of the biological approach, the medical approach with the behavioral approach. Once these patients begin to recognize and appreciate the suffering component of pain, then we assign activities or self-observation in ways that helps them to really to kind of get that in a real world sense, to understand what the psychological factors and social factors may have on their experience of pain, and their experience of kind of motor withdrawal, and how we target those factors biobehaviorally. So we ask them to keep logs, really, and self-monitoring has been shown across most disease states to improve things. If we want to get people to lose weight, we ask them to monitor their intake, and that has its own effect without any training whatsoever. Want to get people to stop smoking, you ask them to monitor their smoking, and it actually reduces the frequency of smoking. And exercise and other behaviors have showed this same effect of the improvement that accompanies simple self-monitoring. So we do that same thing with the pain population, and we ask them to pay attention to things that make their pain worse and what makes it better. And typically with pain patients, they're so focused on their distress that they're not as aware as they might be on times when actually pain is less intense. And so by logging their experience of pain and their function, along with various factors that can improve pain and function, they begin to develop an awareness of these factors that are so essential in their pain experience. Understanding, for example, how stress might affect their pain, or understanding how the analgesics they're taking may affect their pain. And one of the things that's striking about having patients keep those records is we've often had patients much more willingly come off opioids when they recognize that, frankly, they're not doing them any good. That when they keep those records carefully, they say, you know, I'm taking this Percocet or Dilaudid or whatever, I'm taking it just because it's been prescribed, but I realize that it's not really, doesn't really seem to help. And when they really study it, I mean, when they really sort of pay attention to it, they recognize that it's not nearly as helpful as they sort of thought it was before. So we keep these diaries as a way of the patient's own sense of insight and education about their own pain and function. Okay, next. So far, just to summarize, acute pain is just a different animal than chronic pain. We really ought to even call it something else. It operates with a completely different set of principles, and that suffering tends to be much more an issue than true sensory or nociceptive input is, and that the biobehavioral approach, certainly from our studies and from many other studies as well at this point, is much superior to a pure pharmacologic approach for managing chronic pain. Next slide. This is a graphic that shows a little bit about what we're talking about. This is how our patients, and frankly our practitioners as well, before they take our course, tend to think about chronic pain. This is a kind of an illustration of how the candle burns this poor woman's finger, and we imagine that there's a sensory input that travels up the nociceptive system. It travels up through ascending pathways in the spinal cord. It goes into the brain, and this poor woman says, ouch. And we imagine a one-to-one correspondence between sensory input on the one hand and the experience of pain on the other. And that sensory model, which is perfectly valid for acute pain, does in fact reflect those messages from the body, but with certain kinds of moderating factors. So there are factors that help to inhibit pain as it comes into the brain. There are factors that are more likely excitatory versus inhibitory factors in how the nervous system works. And in acute pain, then, this model really does work. And the interruption of the message through medications or interventional strategies of various kinds is the primary management strategy. This is perfectly reasonable for acute pain. But acute pain evolves into chronic pain at 3 to 6 months. And that's the point. Gradually, this changes from focus on sensory to focus on brain. Next slide. To give you an example of this, nociception is not the same thing as pain. So nociception, this is just a fun thing. Nociception is a signal. It's just information. It doesn't have any meaning. And so to give you a visual analogy, this image on the screen, for most people, it looks darker on the top than it does at the bottom. And we process that image using a variety of cues. But if you move to the next slide, what you'll see is if we remove the middle cue, that in fact the intensity of shading from top to bottom is exactly the same. So visual information is processed neuronally in the same way that pain is, and it is quite dependent upon contextual cues. Next slide. So the pain experience attributes meaning. It's a decision, really. It's a decision by the brain that the signal, the pain signal, is a serious threat, and it's an active decision generated by the motor cortex that attributes meaning to it. So what we try to do in our program is to help our patients understand, and frankly, we have to start with our practitioners, that pain and nociception can be dissociated, that they're not the same thing. And I've got 2 examples here to show you the difference. So let's go to the next slide. So in the first column, or on the first slide on the left here, this gentleman is experiencing no pain. Now, this is a part of a kind of a spiritual or religious kind of event, but none of us can see those hooks linked into the, kind of driven into the skin like that and pulling up and not imagine that it's painful. That looks mighty painful to me. But this guy, like yogis walking on hot coals, doesn't experience pain. So there's clearly nociceptive input there, right? We would all agree. If you stick a hook through my back, I'm going to feel pain. But that nociceptive input is not registering in the brain at all. So we can experience nociception, but no pain. In the second example, we can experience pain without nociception. So let's see if we can make our video work here. This is called the rubber hand illusion. And Rachel's going to do her best to show it to us.
You're sitting at the table, your left hand is in normal position. You can't actually see your right hand because it's behind the screen. And in front of you, I've put a rubber prosthetic hand. Okay? Now, what I'm going to do is show you how malleable your sense of body is. I'm going to start brushing, stroking your right index finger at exactly the same time as the rubber finger and in exactly the same place. Now as I do this, right now you're feeling touch on your right hand, but after a minute or so, you'll start to feel...
Oh, that feels very strange. I'm starting to feel it in that hand.
Okay, so you're feeling the touch. You feel that I'm touching you.
On the hand?
On the rubber hand.
Yeah.
If I get you to quickly close your eyes and point to your index finger with your left hand. Yeah. So that's pretty well, where people will actually feel a displacement of their hand and that it's actually where this rubber hand is. And the illusion is actually strong enough that if you threaten or strike this hand, you actually have a genuine physiological response.
That was very strong. My heart's going.
That's right. So I distressed some undergraduates doing that. And if we put electrodes on you to measure the response, you actually get the same response, me striking this hand, as if I'd struck your real hand or your left hand.
Wow.
So it just demonstrates in only a minute that actually your sense of body and your sense of self is quite changeable and manipulatable.
Wonderful. Thank you for getting that to play for us. That's a marvelous example. It's called the rubber hand illusion, and we can demonstrate that pretty readily in the laboratory. But that is an example of, oops. You probably have to go back to where we were in the slide deck before. But that's an example of how there is clearly no nociceptive input whatsoever when he hits that rubber hand. But she has already, just in a minute or two, sort of almost like the brain is rewiring itself to experience the rubber hand as her actual hand. And so the point is that using examples like this with our patients, we can begin to help them truly distinguish, but now go back one, truly distinguish between nociceptive input, sensory input on the one hand, and distress and suffering on the other. So now kind of reconceptualizing this figure to represent chronic pain as opposed to acute pain, we now see that the figure is more appropriately addressed as pain as being an output of the brain when it's chronic, as opposed to an input of the brain. And pain now is not so much a sensory function as it is a motor function, and that the brain is actually activating messages to the body as opposed to from the body. And chronic pain is primarily due to brain-based changes, to learning more than it is to sensory input. So our goal now in the better management of chronic pain is in fact understanding this role of the brain and understanding how to rework brain function as the primary management strategy for chronic pain. That's essentially the lesson that we've learned by understanding the role of the brain in chronic pain and understanding how we really need at the office level to change the way we deal with our patients. Al, you want to talk about the office level a little bit?
You know, it's a significant shift away from we as medical professionals, our reflexes to use a medication to interrupt distress. And we go into healing professions for compassion and empathy, and patient satisfaction scores drive us nowadays. And so our inclination is to try to find a solution quickly. And pharmacology has always promised to offer that, but it's the wrong emphasis on treatment for a chronic pain syndrome. Again, not devoid of opportunity with some pharmacology, but it can't be the primary treatment. And so we have to reorient ourselves. We have to re-educate patients. And it really does emphasize why the team with the expertise of a psychologist and the expertise of a physical therapist on the activation side can be so helpful and important at addressing chronic pain.
Okay, next slide. So this is really an effort to help the practicing practitioner. Often there's a hesitancy on the part of patients to be referred to behavioral health. The message to them can be, we think pain is all in their head, or we think that somehow this is a product of psychological issues, behavioral issues. And so a lot of the challenge to practicing physicians and nurse practitioners and PAs and so forth is how we can build this team. How can we get them to behavioral health? How can we get them to rehab services? How can we engage with our help our patients engage in this more comprehensive process? So what we try to do is encourage them to explain exactly what the behavioral health role is here, and to normalize team treatment. They're not being passed off. They're not being, farmed out. This is a normal part of, and an accepted part of comprehensive and evidence-based chronic pain treatment. So next slide. So what we're trying to do from the behavioral perspective is understanding the unhealthy responses of the brain. And so the overarching strategies with counseling and social work and psychology practitioners is to help patients understand the learned passivity and helplessness that accompanies chronic pain is all a part of the syndrome. It's a normal part of the process of chronic pain, and that we need to address that passivity. We need to, it is intuitive when we are in pain to withdraw and be passive. And while that's helpful when you've got an acute pain process, that's counterproductive when it's chronic pain. And so we have to help them to push past their intuitive response of being passive, of lying on the couch, of not being engaged, to re-engagement. And that's really where the physical therapy and occupational therapy becomes such an important partnership for us. We address the normalcy of demoralization of that not only pain brings, but loss of function brings, and all of the consequences, loss of pleasure, loss of income, loss of recreation, loss of sense of self, loss of, that the kind of role definition that many people have for themselves, where they used to be the breadwinner, and now they can't work. So all of those things are the consequences of chronic pain that contribute to the chronic pain experience. And in particular, that passivity, that desire to not do too much for fear that they'll increase their pain, actually serves the function of creating a fear and avoidance cycle, which makes pain and distress even worse. So all of those are targets of the behavioral partner that the practitioners in the medical office can engage with to help their patients move forward. Next slide. I think I've kind of already covered this, but behavioral activation decreases pain, actually. When people initially start to move, they'll often experience increased pain, and it will put them off to movement, and they'll kind of get back on the couch. But actually, what we know is that the more active people are, the less pain they have. The more activated, the less suffering. And so if we marry activation and analgesics, we can address both ends of the pain cycle, both the nociceptive input as well as the suffering experience. So what we try to do is give patients an active role in their own care. We try to help them understand that, in essence, they're our partner in this. We are doing what we can in terms of reducing sensory input, but they have to address the behavioral activation part themselves. And it's kind of a quid pro quo. We'll provide these interventions, but we also need you to engage more actively. And we set the stage for helping them understand why that is, which is often the missing link. Often patients don't get the why. They know we want them to go to the gym. They know we want them to go to rehab. They don't understand why it's so critically important. And so that's why we share this conceptual model, this kind of paradigm shift for how it is that we deal with chronic pain. Okay, next slide. So these are just examples, quick examples of the difference between passive and active strategies. So if the goal is to reduce sensory pain, the passive strategy is to take a pain med. The active strategy is teaching them to do diaphragmatic breathing, which dramatically decreases sensory pain and increases parasympathetic kinds of contribution. If we want them to reduce suffering pain, the traditional approach is to take an antidepressant. The active strategy is to use cognitive behavioral psychotherapy to help them to address the suffering component of pain from the brain perspective. When fear of pain is at issue, when people are hesitant to engage in something that they think is going to hurt them, they tend to avoid the activity. But we know from behavioral science that the more you engage, the more you approach a feared stimulus, the less the fearful response, and so forth. So we have always an accompaniment, a replacement active strategy for passive strategies that historically have been used. Okay, next slide. So that's kind of the neuroscience base for what we try to do in our training program. As I said, we've developed a highly codified curriculum, and this is essentially the way we present the curriculum to the practitioners who enroll in our training. We go through some fundamentals sessions, which really are kind of lunchtime sessions where we introduce the biobehavioral framework that we've just talked about. We introduce stages of change theory, which tries to match the intervention that we use to the patient's readiness to accept it. In the third lunchtime sequence, maybe in month 3, we talk to them about how best to talk to patients about opiates, how best to address opiate usage, and critically, how, when we understand that there's an opiate use disorder, how it is that we need to have the language that enables us to make sure that we don't continue to prescribe opiates. Then with that framework in place, then we do an 8-hour workshop where we train the language and clinical skills that match this new science that we've just outlined. That's the 8-hour workshop portion that typically happens in month 4. And then we follow that up with 3 more lunchtime sessions, each about a month apart, where we mentor now the changes that we hope will take place in practice. We bring our participants back. This is all virtually done. They join us virtually, and we try to mentor them in helping to make sure they're making some of these changes or address the challenges that they've faced and hear about their successes, and often their surprising successes with patients that they've tried these strategies with. So we break those into 3 sessions: how to best use a team approach, how to practice the skills that we've trained, particularly communication skills, and then how to kind of review and celebrate successes as well as address challenges that people face. Next slide. In each of these, now breaking this down, the biobehavioral framework, we learn how to turn what we've just talked about in kind of theory, how to really have that conversation with patients in a way that they'll understand it. We've all been thoroughly coached in the sensory models of pain, so it takes some skillful conversations with patients to help them really understand a different way of thinking about it. It's hard enough for us to convince practitioners to do this. The next step is how to get them to do this with their patients in turn. So we practice those conversations. We practice them as language skills and do a lot of role playing to help understand better how to convert the theory into practice. Next slide. Then the stages of change, to break that down. There's a different role that we assign to practitioners based on the patient's readiness to change. And I'm sure that readiness to change is not a novel concept to this group, but we use it in particular in tailoring the approach in the office to the patient's readiness to hear it, and how it is that we effectively begin to sort of move them from one stage to the next. And we use the PEG, which is an instrument that looks, it's a 3-question questionnaire that quantifies pain intensity, affective experience, and function in a simple way of quantifying where patients are at with regard to their pain and function, and then being able to track their progress over time. Next slide. And then in the third one, breaking this down, we emphasize how it is that we communicate compassionately and effectively with patients to be better about when we are going to use opiates, about how to use them, how to set boundaries around their use, how to set appropriate expectations with their use, and in particular, when practitioners diagnose that there is in fact a substance use disorder, how it is that you can effectively and compassionately bring the opiate prescribing to a close, as you must do, and to help them understand why you're doing that, and then how to best use buprenorphine as an opiate replacement in patients with chronic pain. Next slide, and this is the last one, I think. This is our 4 PCP faculty. We're trying to encourage practitioners to engage with a team, and this is in fact our team, and we model exactly what we're asking people to do. So Dr. Chilimsky and I were the ones who originally came up with that pilot study and the work that we did before the opiate crisis, and now we've recruited a number of faculty members to address various aspects of chronic pain. So Gisela Chilimsky is a pediatrician, a pediatric gastroenterologist who addresses this with children. Sandy Hilton is a physical therapist who's on the West Coast and has done really quite good work with us in understanding the role of rehabilitative services and how to communicate effectively across disciplines. Dr. Ted Perrin is an addictionologist here in Cleveland who helps us with our opiate communication process. And then our guest and collaborator, Dr. Musa, and Dr. Bain were the primary participants in the development of our curriculum, helping us understand just what it's like to treat chronic pain in the office. And so this is our group. This is our faculty. So with that kind of brief outline, I can open things up to questions or comments or discussion as you like.
That was great. Thank you so much for sharing that information. And I'm really looking forward to sharing this recording as well. Are there any questions from any of the folks on the line? I saw one question, and I think it was back when Rachel was commenting about how concerning it was to see the long use of opioids and the clinical response to that. Are there any tools or apps that help with tracking these symptoms and responses?
You talking about the hyperalgesia response?
Yes.
For patients, like when doctors are working with patients and they're asking them to track their symptoms, like keep a log. There's so many apps and things these days. I was curious if there's any like pain management apps that are recommended or tools to kind of, log and diary, like you said, just thinking of ease of the patient.
So, Jeff, if I could comment there.
Yeah.
This whole approach helped me, help facilitate in practice. We've talked a long time about how important shared decision making and patient-reported outcomes are, and they've been implemented in a variety of disease algorithms and care management. And in chronic pain, that was really helpful to me to have some tools. And the one that stands out is avoiding the 0 to 10 pain scale and really emphasizing more of the PEG scale, which does include a patient's self-report of their severity of pain over the last week, but it also includes their pain experience and how it's affecting their choices in life and their actual specific activities in life. And so that's a quick surrogate that's patient reported that helps you track success or failure of your overall intervention. And obviously you can isolate that to more even on the response to the benefit or lack of benefit in an opioid. So when you see them, asking for an escalation in their opioid dose, but they're becoming less functional, that kind of tells you, you can point out to them, well, that's really not working, is it? And increasing it has been shown not to work. And that's sometimes the biggest challenge is because they're so often from a patient's perspective, more will help, more will solve this. And that becomes the real obligation of us as clinicians to share data that says, indeed, it doesn't. But if we include a biopsychosocial framework and not just emphasize the biopharmacology, that'll help. And sometimes it's what alternative pharmacologic agent might we use to an opioid to be more targeted to what the pain syndrome is, how is it being perceived and how is it being driven, and then we might target a non-opioid analgesic sort of approach. Jeff, anything you want to add to that? I think the PEG scale has been really helpful in practice because it's so easily done at the point of care.
Yeah, and I think, again, I rely on a couple of things, on self-monitoring to sort of demonstrate that pain doesn't improve nearly as much as they might have thought. But also I share a number of different patient stories. I can't tell you how many patients with 5 or 6 or 10 years of chronic pain we have taken off opioids and their pain scores don't change. So often we ask them to suspend disbelief and say, look, let's do a trial here off opiates. And what they'll find is that not only does their pain not increase as a result after they've made the adjustment to being off them, but their energy level improves, their get up and go improves, they feel more engaged and less beleaguered with the side effects, cognitive and otherwise, that opiates bring with it. So I use a lot of patients' own stories to help with that.
Right. Any other questions? I see somebody typing in the chat, so I'll give it a moment. Oh, the comment was just made. Self-observation is a great tool to use.
Yeah.
Thank you, Ruben.
Yeah, and we do. We use it quite reliably and make a big point of it. When people don't, when people say, "Well, I've assigned this homework and my patients don't really do it," that's often a failure of how it is we introduce it, and then how it is that we emphasize it by paying close attention to the self-observations that the patients bring back to us. So I found that a very useful tool as well.
Great.
So if I could add a comment about the importance of the team and the challenge of having a team that's existing together in real time and the costs that as Jeff pointed out, that become prohibitive in most health systems. But it still is a team that does form itself in a shared knowledge and a shared approach and a shared care plan. So it's so different than the referrals I used to make years ago, where then the patient's expectation was, well, I'm going to the psychologist because if they're willing to go, because he or she's going to fix me. And so it's an unrealistic expectation. It's very clear that each one of us is going to stay engaged in their care and in this sequence and when they're ready to address it in those other areas, but that it is a shared experience. And where the virtual part comes in is we actually for 2 years were able to continue this until I retired, where we would have a monthly virtual meeting. It would usually, we would spend an hour, but we would talk about multiple patient cases and where we are in this whole continuum of care and to help prep for the next visit, which adds to that efficiency issue that the pilot demonstrated. But that shared language and that shared approach and a shared care plan is so valuable. And then it reduces the chances that patients are splitting, but because they're hearing things differently from each of us in different terms and different language.
Right. In the essence of time, I think we're going to move on to the next slide. Rachel? Do we have their contact information in case anyone wants to reach out? Is that on a slide?
I don't believe we have it on the slide, but if it's okay with both of you, I can share that in our follow-up with the participants.
Sure. Of course.
So go to the next slide. This one's not. Okay. So we have our Consortium Chronicle, which is a newsletter that goes out. And we also have the evaluation for today. All our slides look alike, so I jumped ahead. Our evaluation for today, if you don't mind scanning this QR code, we do really value your input on the evaluation of our programming. And since we are funded through the OD2A local grant with Cuyahoga County Board of Health, we are evaluated on our programming. And so your input is really valuable. If you wouldn't mind scanning that QR code and providing feedback, we'd greatly appreciate it. Next slide. We have a speakers bureau that recently launched. We're calling it SPEAK. We're not very creative, but Substance Use Prevention, Education, Advocacy, and Knowledge. So given that we focus a lot on the community education piece, we also try to reach out to providers, to organizations, nonprofits, community-based groups who are looking for speakers. So you can contact us and we can put you in touch with some of the expertise like we had today with Dr. Musa and Dr. Janata, or on a variety of issues. If you go to this webpage, you can click to see some of the offerings, and we'll connect you with experts, subject matter expertise to provide that programming. If you are an expert and you have a presentation that you would like to make available to others, we also have the form on this website that you can submit your information, and we can put you in our database so that we can connect organizations to you. So it's a two-way street here. But we are looking just to navigate and help connect people. And here is the slide for the Consortium Chronicle newsletter, which goes out monthly. So if you're on our Northeast Ohio Opioid Consortium list, you should be receiving this email to you, usually mid-month. And then if you scan this QR code, it will take you to the website where you can access past issues. We always catalog those. So if you can't find them in your email, you can always go to this website and you can sign up to get this newsletter. This newsletter includes state updates from Ohio. It also includes national updates and also training and educational opportunities. Next slide. Again, here is the QR code to take that evaluation, and we greatly appreciate your feedback and your response on this. Next slide. WellLink, that convenes the Northeast Ohio Opioid Consortium, has a annual conference called Connect NEO. It's coming up on May 14th. So we encourage you to participate. It's an in-person convening at Playhouse Square in Cleveland. And we have panels, including a behavioral health breakout session at this event. The agenda is all online, and you can register online as well. Next slide, please. We have our next forum is going to be planned for hopefully June. This is a tentative date because we're still arranging and confirming the speakers, but we were going to highlight some policy opportunities to advocate for non-opioid choices. And so the Northeast Ohio Opioid Consortium recently became a member of the Voices for Non-Opioid Choices. And I will actually be representing our region at a Capitol Hill Day in May to talk about just the need for non-opioid choices and to make sure that people have access to those different therapies. And so look forward to our next June program on advocacy in that arena. Next slide. And that is, I think, it for our session today. I think 1:15, we're right on the money. So we appreciate Dr. Janata, Dr. Musa. Thank you so much for sharing this education, and we look forward to the video recording will be put on our Consortium Education Series webpage, so all can view and share it as they see fit. And we hope that we have generated some interest that would like to hear more about this program. We'll be connecting with you both if there is interest in expanding the knowledge outside of our group. So this was really enlightening, and I appreciate your time, and thank you all for joining us today.
Thank you so much. This was a really fascinating training. I appreciate it.
Great. Thank you, Siobhan.
Thanks
Thank
for
you.
inviting us.
Yeah, take good care, everyone. Appreciate you being here.